So what's the advantage of 3D mammography? So 2D, you can see here that you have the top plate and the bottom plate with the breast being compressed, and the X-ray beams are coming from on top. And you can see different things within the breast. But the picture that you get is this. So if there could be a cancer here, but because of the overlapping tissues, you can't see it. So there's the 2D superimposition causes problems, and it can obscure cancers. Well, 3D helps get rid of that. It's superimposition, excuse me. Next slide. So think of it this way. This is what we used to be able to see, and what we see now, we actually have slices in between all of that. And so then we can see this standing out on its own. It's not being covered by other tissue in the breast. So 3D tomo is tomosynthesis, but we say tomo, proven to detect 20 to 65% more invasive breast cancer compared to 2D alone. An average increase of 41%, which is huge. And a lot of these times, these cancers are smaller than we would have seen it on the 2D. We catch them earlier, which is great. It's proven to reduce callbacks up to 40% compared to 2D alone. So some of the things that we see, like overlapping vessels or overlapping tissue that we would have called back, we see that they're absolutely nothing on the 3D. Now, the caveat is that when you get your first mammogram that happens to be 3D, even if you've had priors, because we're seeing so much more of the tissue in between, oftentimes you get called back for that first one, but once you have your second one, we see those callbacks go further and further down. Usually, so we just put a new unit up in the Newport Richey area. So usually within the first year, we might see a little bit more callbacks, but within a year, those go down. So just a heads up on that. If you do get a 3D, decide to get a 3D, which I would encourage, you may get called back just because we can see more of your tissue. Okay. So this is actually what it really does. So here's the breast down here in compression, and up here, the image, the X-ray machine is going to be making an arc, and it takes pictures in a 15-degree arc, and then those are reconstructed. And I know it feels like you're being squished in there for a long time, but that arc actually only takes 4 seconds. So keep that in mind. Those are reconstructed into 1 millimeter slices. And on these 3D machines, kind of like I mentioned before, you can get 2D only in that machine, you can get 3D, and you can get both. And there's also what's called a C-view or a synthetic. And actually it's been approved that we can use that alone as opposed to a 2D. So different places have different protocols, but those are different things you may hear. Okay, so on this image, I'll put your eye over to this area right here, and this is a 2D image. Slide. And even on the 2D images, here's a little different positioning. We see it again here. And this is kind of that spot compression. They put a little extra compression just in that area to try and spread the tissue out. And it still persists there. Next slide. And here it is. So when they did the tomo images through that, it's actually an overlapping vessel here, which is absolutely nothing to be of concern, and it's completely benign, and that patient would probably not have been called back. Now, one thing that we have really improved with 3D, or us as radiologists have been able to do better at, is diagnosing infiltrating lobular carcinoma, which is the second most common type of invasive breast cancer. And on this image, I don't know if we could really call anything on this, but next slide. There was something, and I'm not even looking back and knowing where it is, there's no way I think anybody could call this. And if it's this area right here centrally, but look at these, what we call spicules. I call it almost like a sunburst appearance. So those are the cancers that we're seeing a lot more of. We're able to diagnose earlier and earlier. So it's an area of distortion. It's the third most common mammographic appearance of a non-palpable breast cancer. So a cancer that you can't feel, which most cancers actually are not palpable. Less common than asymmetries and masses until 3D, which we're seeing a whole bunch more of now. And it's very difficult to diagnose. So what is distortion? It's defined as the normal architecture of the breast is distorted with no visible, well-defined mass, and it has those spiculations radiating from a point, and that's retracting that tissue. So again, this image down here is kind of like that starburst appearance. And if you can appreciate it, right in here, you're starting to see that starburst appearance. And this is on the 3D image. 2D image would not have shown it very well. As you can see here, this is that same patient. Without that 3D tomo image, that would not have been found. Again here, a little more subtle. But there you go. Now, when you do the 3D images with those compression views, you really start to see those little spicules and this kind of starburst appearance right here. A little more subtle on this view, but definitely right here. Okay. And that's just the correlate to that. Shockingly, it looks bigger on your mammogram. This is an ultrasound, and this is this little lesion right here. Okay. So here's another example. Again, this is the 2D image here on the left. And if I could, this one's subtle, but if you start to see these little spicules here, that's another area of concern. And again, we see that up here, which very, very, very difficult to appreciate here. All right. On this image, again, there's a little distortion in the inferior part of that image on the left, and you can start to see those spicules on the 3D image on the right. Same thing, you have your 2D. That little triangle is where it's for a palpable abnormality. So if you feel something abnormal or something new or something painful, tell the technologist and they will put a marker on there, and that brings the attention to us as the radiologist. That's the area that is concerning. And again, on the image on the right, inferiorly, you'll see kind of that little distortion along the edge. It's not that nice and round appearance. And this is that subtle cancer on the mammogram. This is ultrasound. And next to this is the MRI. So much more expansive, much bigger than what the mammogram actually shows. So one thing I just wanted to talk about briefly, because I know there's a lot of concern about radiation, and there's numbers and things on here, but the radiation dose is on average for a typical mammogram with 2 views is about 4 millisieverts. A really big fancy word, but it's just a measure. The radiation dose from a 3D is similar to slightly higher than what our normal 2D mammograms are for. And just for your information, a flight across the coast is about 20 microsieverts. So small dose, but you're still getting radiation just by flying in a plane. So this is just kind of an example of the different kinds and levels of radiation that people can get. So again, here is an example of the differences in the mammograms. The 2D is under 0.5, so again, like 0.4 millisieverts. And the synthetic 2D with 3D is just above that. And compared to just natural background radiation, just by being around for a year, you'll get normal radiation from the earth and from the sun. And I also wanted to talk briefly about COVID vaccination and mammography. I think that's been on the news on different stations, recommendations that potentially to hold off on your mammogram for 3 months after your second dose of the vaccination. And the reason, it's been said that it can mimic breast cancer. What it can do is actually after the vaccination, on the side of your vaccination, everybody talks about that pain and maybe a little warmth right at the site of the injection. Some people also feel some nodules under their armpit. Those are the lymph nodes that are reacting to the vaccination, and they're building up your immunity, and those can swell. It doesn't happen to everybody, but certainly can happen. And so that was the thought. We don't want people getting their mammograms and then you see these lymph nodes and then we biopsy them. Well, we discussed this as a group, and what we've done is, because of all the issues with last year, people not being able to get their mammograms because they were put to a halt basically for a short time and things were delayed, we didn't feel that that was a good thing to keep delaying. This is very important for people to continue doing their mammograms. But we do ask that if you've gotten your mammogram to just tell us when you had your last your last vaccination and on which side. So if we do see lymph nodes, we can say, okay, this is probably reactive. We'll recommend an ultrasound, make sure there isn't anything else. And then we'd have you come back in 3 months and make sure those lymph nodes have gone down. If they haven't gone down, that might require a biopsy, because by that point, the reactive tissue should have normalized.